Hello and welcome to my channel for audio medical basics to listen to when you don't have the free time or free hands to hold a book. If you like, please don't forget to like, share and subscribe. Today I'll be reading from my favorite book series, Case Files by Lang McGraw-Hill. This book offers medical info in the form of cases, questions, then full answer and explanations. Usually the cases are long and full, as you can see here. Long, full cases, juicy, very nice for an exam. But I will be reading the shorter, more direct case presentation from the answers section to give you a full, concentrated, helpful information. Here we go on. The great thing about this book that it does not only give data and in boring questions and answers form, it actually explains to you how to approach, give you definitions and differential diagnoses and such information in a nice case-based manner. As you can see here, we start with the case 4. You get the cases, you get the cases, you get the clinical approach, you get the questions also that you can answer. See questions and answers with the answers available, and at the end there's a nice brief of what you have just studied. It is good for second or third year medical students, depend where you study, who are tired of cramming full linear medical textbooks into their heads and would like to learn and understand in a nice, relaxed, case-based fashion. Today we're going to have a case about peptic ulcer disease. So, summary of the peptic ulcer disease case. A 37-year-old man presents with complaints of chronic and recurrent upper abdominal pain with characteristics suggestive of duodenal ulcer, which are his pain is burning, occurs when the stomach is empty, and is relieved within minutes by food or antacids. He does not have evidence of gastrointestinal bleeding or anemia. He does not take non-steroidal anti-inflammatory drugs, which might cause ulcer formation. But he does have serological evidence of H. pylori infection in our case. So, a 37-year-old man presents with complaints of chronic and recurrent right upper abdominal pain, characteristic of duodenal ulcer. Burning pain, empty stomach, pain is relieved within minutes of food or antacids. Analysis. What are the objectives in this case is to know how to differentiate between common causes of abdominal pain by historical clues, to recognize clinical features of duodenal ulcer, gastric ulcer, and features that increase concern for gastric cancer. Also, the objective is to understand the role of H. pylori infection and use of non-steroidal anti-inflammatory drugs in the etiology of peptic ulcer disease. Finally, understand the use of interpretation of tests for H. pylori. So, consider this. In this patient, the symptoms are suggestive of duodenal ulcer. He does not have alarm symptoms such as weight loss, bleeding, or anemia. And his young age and chronicity of symptoms make gastric malignancy an unlikely cause for his symptoms. Helicobacter pylori commonly is associated with peptic ulcer disease and requires treatment for cure of the ulcer and prevention of recurrence. This patient's symptoms also consistent with non-ulcer dyspepsia. So first we'll start with some definitions. Dyspepsia. Dyspepsia is pain or discomfort centered in the upper abdomen, mainly or in or around the midline, which can be associated with fullness, early satiety, bloating, or nausea. Dyspepsia can be intermittent or continuous, and it may or may not be related to meals. So dyspepsia is pain or discomfort centered in the upper abdomen, can be associated with fullness, early satiety, bloating, or nausea. Could be intermittent or continuous, may or may not be related to meals. Okay. There is also functional dyspepsia, which is non-ulcer dyspepsia. Its symptoms as described for dyspepsia persisting for at least 12 weeks but without evidence of ulcer on endoscopy. So, functional dyspepsia, non-ulcer dyspepsia, is same as dyspepsia, but the symptoms, but it persists for 12 weeks without evidence of ulcer on endoscopy. Helicobacter pylori. Helicobacter pylori is a gram-negative microaerophilic bacillus that resides within the mucus layer of the gastric mucosa and causes persistent gastric infection and chronic inflammation. It produces urease enzyme that splits urea, raising local pH and allowing it to survive in the acidic environment. So the main culprit here is Helicobacter pylori, a gram-negative microaerophilic bacillus, stays in the mucus layer of the gastric mucosa, causes persistent gastric function and chronic inflammation. Persistent gastric infection and chronic inflammation. It produces a urease enzyme that splits urea, raising local pH and allowing it to survive in the acidic environment. The clinical approach in this patient. Clinical approach. Upper abdominal pain is one of the most common complaints encountered in primary care practice. Many patients have benign functional disorders, but others have potentially more serious conditions such as peptic ulcer disease or gastric cancers. So, dyspepsia mentioned earlier, it can be produced by a number of other gastrointestinal disorders so not only peptic ulcer, dyspepsia can be caused by other disorders. So differential diagnosis we can say here. So first we have the gastroesophageal reflex. Typically produces heartburn or burning epigastric or mid-chest pain, usually occurring after meals and worsening with recumbency. So gastroesophageal reflex. Burning after meals, worsening with recumbency. Other causes of dyspepsia is biliary colic. Biliary colic caused by gallstones typically has acute onset of severe pain located in the right upper quadrant or epigastrium, usually is precipitated by meals, especially fatty meals, lasts 30 to 60 minutes with spontaneous resolution and is more common in women. So this is biliary colic. Biliary colic due to gallstones has acute onset with severe pain, located right upper quadrant of epigastrium, precipitated by meals, usually, especially fatty foods, lasts for 30 to 60 minutes with spontaneous resolution, and it is more common in women. Finally, we have also another cause of dyspepsia is irritable bowel syndrome, which is a diagnosis of exclusion, but is suggested by chronic dysmotility symptoms such as bloating and cramping, often relieved with defecation, without weight loss or bleeding. If these causes are excluded by history or other investigations, it is still difficult to clinically distinguish by symptoms the patients with peptic ulcer disease and those without ulcers. So that is non-ulcer dyspepsia. So irritable bowel syndrome, diagnosis of exclusion, discomfort relieved with defecation, does not have weight loss or bleeding. And the rest is in part 2 of this peptic ulcer case. The rest of the case will be a short one. Thank you very much. Thank you for watching. Please like and subscribe and comment in the comment section.